Good evening to everybody. On behalf of IAP TNSC, I welcome one and all for this wonderful postgraduate teaching program. First, I request our President, Dr. Ramesh Babu, is dynamic President, currently is HOD and Department of Pediatrics and Medical Superintendent of Thermopylae Medical College. He will deliver the presidential address.
Thank you, Dr. Rajendran, for your introduction. Good evening, all. IAP TNSC is conducting this postgraduate teaching program for the past 2 years, and our dynamic secretary, Dr. Rajendran, is instrumental behind this. At this juncture, I welcome all the state office bearers of IAP TNSC, the respected President 2021, Dr. Ismail sir, and President-elect Dr. Suresh Babu sir, the Secretary Dr. Rajendran, Treasurer Dr. Gopal Subramanian, respected judges for today's program, Dr. Janani Madam, Dr. Srinivasan sir, Dr. Rama Madam, Dr. Ramesh sir, and today's chairperson, Professor Nirmala Madam, and the moderators, Dr. Ujjal Podar, and Dr. Uma Madam from Meenakshi Mission, and dear students who are going to present today's session. I have got 2 requests, one for the presenters and one for the faculties. As National Medical Commission has made it clear that the postgraduates should present at least one poster and one research article apart from their dissertation for their exams. For their exams, and it is mandatory, and as made it as mandatory as an eligibility for getting the hall ticket in the exams. So they have to present paper in a state or a national conference. For that, to become a member of IAP is mandatory for them. So I request the faculties to motivate their students, postgraduates, both India as well as DNB postgraduates, to become life member of Indian Academy of Pediatrics. And also, I request the postgraduate students who are presenting to intimate and motivate their fellow postgraduate students to become member of IAP. With this request, I wish this program a success. Over to Dr. Rajendran to carry out the further proceedings. Thank you.
Thank you, Dr. Ramesh. And now, on behalf of IAP TNSC, I welcome today's our President, Dr. Ramesh Babu, and President-elect Dr. Suresh Balan, and President 2021, Dr. Ismail, and Vice President, Dr. Annamalai Vijayaragan sir, and AAA, Dr. Thirumurugan, and Editor, Dr. Dashani, Joint Secretary, Dr. Balasubramaniam, and I welcome all judges, Dr. Janani Shankar, and Dr. P. Ramachandran sir, and Dr. S. Ramesh, and Dr. Rama Chandramohan, Dr. S. Srinivasan from Pondicherry, and I welcome postgraduates from Madurai Meenakshi Mission Hospital, and that Muhammad Altaf and Gayatri and Runda. And I welcome today's chairperson, Dr. D. Nirmala. She is currently is a professor and head Department of Pediatric Gastroenterology, Institute of Child Health and Hospitals at Chennai. I welcome Dr. Nirmala Madam. I welcome today's moderator, Dr. Ujjal Podar. He is a well-known figure internationally, and he is currently professor and head of the Department of Pediatric Gastroenterology, Sanjay Gandhi Institute of Postgraduate Medical Science in Lucknow. He has many publications against his credentials and a lot of books as well as international journal also. I welcome Dr. Ujjal Podar sir. I welcome Dr. V. Uma Muralidharan. She is currently is a consultant pediatrician and Meenakshi Mission Medical College, Meenakshi Mission Hospital and Research Center, Madurai. I welcome Madam, and I welcome all the faculties as well as students also. And once again, on behalf of IAPT NSA, I welcome one and all. Now it's a handout to Dr. Nirmala and followed by going for the deliberations. Dr. Nirmala, madam.
Good evening, faculty and all the others who logged in. Today we have a case presentation by the team from Meenakshi Medical Mission, and to moderate the sessions we have two eminent teachers. One is a teacher of teachers, Professor Ujjal Podar, who is currently the head of the pediatric gastroenterology at Sanjay Gandhi Postgraduate Institution at Lucknow, and he's a very good friend of mine, and he's a very well known, he's a very eminent teacher, and he's got many international presentations, and the students must be really happy to have a teacher of his caliber to be a moderator on this session today. And another one is Dr. Uma Muralidharan, though I don't know her personally, but she's a senior consultant pediatrician at Meenakshi Medical Mission, and I think she's a trainer for these three students who are going to present today. I think without wasting much of time, I think we'll go on to the presentations straight away. Okay, sir?
Yeah, thank you, madam. And I request Dr. Ujjal Podar sir to tell few words.
Yes, sir.
Good evening, everybody. I must thank Dr. Rajendran for remembering me. I conducted one such session last year, and probably it was almost similar kind of case, multi-system, but neonatal jaundice. And this time again, we are going to discuss the neonatal cholestasis. At the onset, I must thank the President, Secretary, Treasurer of Tamil Nadu IAP for involving me in this teaching activities. Nirmala, thanks a lot for your kind introduction. Nirmala is our pediatric gastro circuit, and she's our examiner as well. And Ma'am Uma, we are going to moderate together. Don't get worried about my presence. Okay, so you have to chip in. It is not that I am always right. I may be wrong in many instances, so you have to correct me, or whenever you feel you need to intervene, please do. So don't hesitate. And the boys and girls who are presenting, Mohammad Altaf, Gayatri, and Bruntha. Three of you are sitting there. Yes, so see don't get anxious or tense. So we will go step by step. We have huge amount of time. In exam, you get just 40 minutes, but here we have 2 hours. Okay, so because we will go step by step, dissect the case clinically, because at your level, at MD level, the clinical discussion is more important than investigation. If a patient comes to with a huge lot of investigation, CT scan, ultrasound, MRI, blah, 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 then what is your role? I, as a clinical teacher, I always say, even in a tertiary care center, in my student, I say, forget about this investigation. You keep them aside. If you go through the investigation of outside physician or pediatrician, you will get bias. And invariably, you will fall into the trap of making a wrong diagnosis. You should take the history directly from the patient, examine the patient, make up your mind, then you go through the, I'm not telling you should not, you should go through the investigation, but not as a primarily getting biased with the investigation. Somebody send you a patient with some ultrasound report and you start thinking that that is the diagnosis. That may not be the diagnosis. Ultrasound is many a times wrong, right? So what we will do, instead of wasting time, Nirmala is familiar with our system of teaching. We conduct our exam in that way also. Probably she also does in the same way. We first allow you to tell the history, but don't jump from the history to examination to investigation. We'll analyze in the 3 steps. First, we'll analyze the history only, and on the basis of the history, we'll try to find out what could be the possible diagnosis. Then we'll go to the examination. Then again, we ask you, after examination, do you like to add something or delete something from the list of differential diagnosis? And once after examination, also we are fixing 2 or 3 diagnoses, then we'll go for relevant investigation, right? So the PG teaching, I was told last time, actually we didn't discuss investigation at all. I don't know, Dr. Uma, are you going to show investigation at the end? I was told that that is not part of the PG teaching.
Madam,
Dr.
unmute.
Rajendran?
Madam, unmute, please.
Sir, we are having slides. If we want, we show you. Otherwise, we will discuss
Yeah,
only
yeah.
based on the history and examination, sir.
Perfect.
Okay,
I was because as at our level we are basically teach DM student, so we go up to the investigation level. But I guess that PG level up to examination will be fine. And at the end, to make it more interesting, you can judge the acumen of your teacher by showing the investigation, isn't it? We may be
Yes, sir.
wrong, but that investigation will tell who is
Yes.
right, who is wrong.
Yes, sir.
So let's start. Rajendran, we should start.
PG Muhammad Aldap, we can start slides. So.
Yes, sir.
Yeah, you can start presenting. Yeah.
Good evening, sir. Good evening, ma'am.
Yeah.
We'll start with the case.
Yeah, please proceed. Yeah.
It's 1.5-month-old boy bought by mother whose reliability is good with complaints of yellowish discoloration of eyes and high colored urine since 9th day of life.
Altaf, you are muted. Unmute yourself. Suddenly your voice is not audible.
Sir,
We
can
can't
I
hear
hear-
you.
So can
Yes,
I-
yes. Yes.
History of presenting illness. Child was apparently normal since birth. Mother noticed yellowish discoloration of eyes since the 9th day of life. She took him to a nearby hospital for which the child was started on phototherapy on OPD basis in the morning and evening for 3 days. The yellow discoloration seemed to have reduced and the mother was reassured. Mother noticed increasing yellow discoloration of the eyes thereafter also. History of passing high-colored urine since the 9th day of life, and also history of passing pale stools intermittently. There was no history of vomiting or lethargy, no history of constipation, no history such as of skin bleeding or injection site discoloration, no history of melena or hematemesis, no history of incessant cry, no seizures or altered sensorium, no history of cough or breathlessness, no history of loss of weight or failure to gain weight, and no history of abdominal distension. Coming to antenatal history, for the second child, no history of abortions. The pregnancy was confirmed at nearby PHC. Booked and immunized, she received 1 dose of TD at 3rd month and 2 doses of COVID vaccine at 5th and 7th month of gestation. There's no history of any drug intake, no history of fever with rash or post-auricular swelling, no history of pruritus, no history of diabetes or hypertension. Quickening was felt at 5th month, no history of UTI, foul-smelling liquor, or purulent discharge. Natal and postnatal, she delivered via labor naturalis. It was spontaneous labor, term baby of 2.8 kg, cried soon after birth. The baby was breastfed soon after birth. He had fast meconium in the first 24 hours of life. No history of neonatal jaundice or seizures. No history of NICU admission or umbilical catheters. The family history is the second born of 3rd degree consanguineous parents. There was no history of any similar illness in the family or no contact with TB. Developmental history: baby recognized mother and whose 1.5 months of age and is exclusively breastfeed since day 1 of life till now. No other feeds are given. 7 times per day, on-demand feeds are given. Socioeconomic, the socioeconomic scale belongs to upper lower scale, according to the scale to 2021. A macroscopic examination of the stools in the ward revealed clay-colored, pale stools and high-colored urine staining the cloth. Shall I summarize, sir?
Okay, go ahead with the summary and then we analyze the history.
That is a 1.5-month-old boy second born of consanguineous, 3rd degree consanguineous parents who presented with jaundice since 9th day of life. It was with high colored urine and pale stools. suggestive of obstructive cholestatic jaundice with no history of any weight gain or failure to gain weight, no history of failure to fight, with no significant antenatal and postnatal history. I'm thinking in terms of neonatal cholestasis.
Hang on, Altaf. Basically what we'll do, that we analyze the symptom. Now, this is a 1.5 months old baby who was brought by the mother with history of chief complaint is jaundice, isn't it?
Yes, sir.
So first we analyze the jaundice, onset, jaundice duration, jaundice, how it is progressing, is it from the history, is it conjugated, unconjugated? If it is a conjugated, then what could be the likely cause? All this information should come from the history. So you have enumerated huge number of no. But history of present illness is elaborating the chief complaints. So chief complaints are only two, I guess. One is jaundice, and it was associated with high color urine. That you said?
Yes, sir.
Okay. Can you start? Can you give describe the jaundice in detail?
So jaundice.
You said something that the baby was detected to have jaundice, given phototherapy, and then what?
And reassured and sent home, sir. But the mothers felt the yellow discoloration was progressing after that talk. So,
no, what is the impact of phototherapy on the severity of jaundice?
They said its severity is reduced, but then after going home, mother felt that the jaundice was increasing even after going home.
So can you describe jaundice further to say that this is conjugated, unconjugated? If conjugated, then what are the attributes of jaundice? Means which can help you to clinically analyze and going towards a diagnosis. We see the neonatal jaundice is very common. Almost more than half of the neonates they have jaundice, and majority are either physiological jaundice or breast milk jaundice. So we need to find out what is the type of jaundice this baby.
So usually physiological jaundice.
No. This baby, no theoretical discussion. This is the patient we are discussing. 1.5 months old boy brought with history of jaundice since day 9. Now you elaborate further the history of jaundice to say this was conjugated or unconjugated.
Since the child has pale stools and high colored urine, we go in terms of conjugated jaundice.
So the history of jaundice associated with high color urine. It is consistent history because this baby was taken to a doctor pediatrician who has given phototherapy. So no one gives phototherapy for conjugated hyperbilirubinemia. So to start with, was there any confusion about conjugated, unconjugated? That's why phototherapy was given? Or without testing, the phototherapy was given thinking that 50 to 60% of the babies will have unconjugated hyperbilirubinemia, so no harm in giving phototherapy. So what
This
is
phototherapy was given before 9 days or after 9 days?
At the 9th day, 9th day.
No, can you give us some information? The phototherapy was given after testing or without testing, without doing any testing?
According to the mother, there was no test done, but it was given morning and evening on an OPD basis.
Without doing fractionated bilirubin?
Yes. Based on
without doing any total bilirubin and conjugated bilirubin?
No, they have not done so.
Okay, fair enough. So you see, you have to come out with this. See, you have to explain, because if there's some doctor has given phototherapy that raised the issue, is it conjugated or unconjugated? So then you should give the explanation that without doing blood test, phototherapy was given, assuming that this is a common garden variety of neonatal jaundice. Okay. Next question is that why did you say it is a conjugated hyperbilirubinemia?
Sir, usually in conjugate hyperbilirubinemia, there is high colored urine and pale.
So what is the history you got? Mother told you she is from the lower socioeconomic status. What kind of history have you got to say that this baby was passing high color urine?
The color of the stool stains the
the urine.
Urine stains the diapers cloth.
Did you get this history that it was staining the diaper?
She told the color was high colored, but I did not get the history of staining the cloth.
No. So see the basic difference between conjugated and unconjugated is not the appearance or color of the urine. Sorry. Yes, sir.
Yes.
Somebody was making comment. No. Altaf.
Yes,
So
sir.
just physical appearance of the urine color will not tell you it is conjugated or unconjugated. It is the staining of the diaper. You need to take the history that if this child was wearing a white color clothes or something, or the bed sheet, was there any staining of yellow staining of the clothes? That will tell that this is a staining the diaper. Just looking at this urine, you cannot say this is conjugated or unconjugated. Even unconjugated urine also look yellow. Okay, you didn't get this history. Now, if it is a conjugated hyperbilirubinemia, then you have to give us the information that what could be the likely cause. So historically, what are the information have you got to say that this conjugated hyperbilirubinemia is due to obstructive cause or intrahepatic cause or metabolic liver disease or PFIC? What are the histories have you taken?
Sir, the child is thriving well.
Okay, thriving well is a good point, but there are many causes where the baby thrives well despite having conjugated hyperbilirubinemia. What else?
There is no history to suggest other unconjugated hyperbilirubinemia like sepsis or metabolic causes.
No, I think you are a little bit hesitant in coming out. See, you started well. This is a baby who is 45 days old, thriving well, having conjugated hyperbilirubinemia. Fair enough. There are huge number of causes of conjugated hyperbilirubinemia. So it is difficult to remember all the causes, but it is easy to remember the groups in different groups. Like you just touching upon, it could be biliary atresia, which is the commonest cause. Where almost 1/3 to 40% of all conjugated hyperbilirubinemia in neonates may be biliary atresia. So if it is a biliary atresia, what kind of history you will get? Secondly, it could be metabolic liver disease, which can cause conjugated hyperbilirubinemia. Then what kind of history you will get? Then it can be various syndrome like intrahepatic bile duct disorder, or PFIC or PILBD, especially progressive familial intrahepatic cholestasis. A set of history you will get in the mothers and the baby. And it can be various infection, either torch infection, which is otherwise less common, but history wise you can get the history of the mother had history to suggest torch, and what is the baby's features to suggest that this is torch or not. So you try to categorize this 4-5 group. Is it biliary atresia or it is not biliary atresia? If not biliary atresia, is it because of torch group of infection or acquired infection or not? Then metabolic causes, what are the historical event you can get, or is it because of PFIC, PILBD group, where what are the specific information you get from the history?
Sir,
So give us this information. And
sir,
then only you
child
can draw a line that this is likely because of this situation. Nirmala, you agree?
Yes, sir. So basically, how do you say that this child is obstructive or not? No,
Yes,
it's a culture obstructive. Then there should be group. Now, how do you say? That's what he wants to know.
the child is a
And how
term,
do you differentiate from other types?
sign is a term child with well thriving 2.8 kg birth weight. So there is no history of any IUJ or intrauterine group, which can point towards intrauterine infections. Secondly, the child had history of pale colored stools, so that points more towards an obstructive cause like biliary atresia or cold ulcers. Metabolic causes, there was no history of any neonatal period vomiting, lethargy, or any seizures, suggestive of any metabolic abnormalities. Sepsis, UTI and sepsis, there was no history of any vomiting or failure to thrive. So with this history,
No. I have given you the hint. Suppose if I say this child is having PFIC, why not PFIC?
Yes, sir.
PFIC
Mother did
babies
not-
are born healthy and they grow well.
mother did not have any
So
pruritus.
you have to say that. Is there any history of intrahepatic cholestasis of pregnancy?
There was no history. There was no history of pruritus.
So, and if you said that in response to Nirmala's question, this is obstructive. This baby is passing pale stool.
Yes, sir.
That is not enough. You have to say this in this 45 days of life, is it consistently pale? Because when you said the history, I clearly heard intermittent pale stool.
Intermittent, yes, sir.
If it is an intermittent pale stool, then it goes against the diagnosis of biliary atresia. You want to qualify further? The stool color is mother said, or what you, because you said that you was the stool and it is a pale. Did you cross check with the mother? This is the type of stool baby is passing from the beginning, or it was yellow, green in between?
It's mostly pale, sir, but sometimes she said that it's colored also.
No, in that case, why then how can we say biliary atresia? See, the biliary atresia is a condition, it is a complete obstruction of the bile duct. It is not that intermittently it is opening up and the stool become yellow or green and again it is closing. That goes against your diagnosis of biliary atresia. So you cannot just rely on the history that this was a good weight baby, 2.8 kilo. This baby is thriving well because this baby gained almost 2 kilo in 2 months. And no sickness, hospitalization, sepsis, vomiting, so it is biliary atresia. No, for any clinical diagnosis, you should go with a positive frame of mind, not negative. In clinical medicine, remember one thing, to make a diagnosis, first you have to give points supporting the diagnosis, not that since there is no history of failure to thrive, since there is no history of vomiting, since there is no history of seizure, no history suggestive of infection, I assume this child is biliary. That is not right. First, you give the points supporting the diagnosis, the obstructive cause, or Nirmala was suggesting that these are the points. Good weight baby, fair enough. Good weight baby can have other condition also. No failure to thrive, fair enough, can have biliary atresia. It is a conjugated, there is no doubt about it. Now you have to substantiate why you thought biliary atresia is a likely diagnosis or number one possibility. Then your statement of intermittent pale stool is incorrect.
When you take a history, you should be very careful. Pale stool is the most important part of the history. So mother may say it is intermittent, but you should ask the color. You have to be careful when you get history of the pale stools. Because even one stool is pigmented, then it goes against biliary atresia. So is your history correct? As our question.
Sometimes the urine can stain the.
No, so then you have to explain that. You cannot say this baby is having intermittent pale stool and it is biliary atresia. Rather, it is other way around. We say this baby is having predominantly pale stool.
Pale stools.
It is likely that once in a while there might be a contamination with the urine. That's why stool color mother has interpreted as not pale. But I believe then you have to be definite and firm in your statement. But you cannot say that in the history of present illness, intermittent pale stool and the diagnosis of biliary atresia. You got my point?
Yes, sir.
Gayatri and Brunta, do you like to make any comment in this respect? You also have taken history. You are the co-presenter. So you have to take the responsibility also. He's not the Altaf, he is the scapegoat.
All of you can answer.
No, have you got the point? Did you take this? What Nirmala was repeatedly telling, the history taking is very important about the stool color. No, not shaking the head. Come out with your statement. It is not the Altaf is going to present case on behalf of you in exam. You will present independently. Okay, go ahead, Altaf. Now, you start. You tell us that point in first. We agree with you. This baby is having conjugated hyperbilirubinemia. We agree. Now give us the historical data to say this is biliary atresia or this is metabolic or it is PFIC-PILBD or it is some kind of chromosomal anomaly or torch infection. These are the broad group, it's easy to remember. If you try to remember that what is the clinical features of tyrosinemia, what is the features of galactosemia, you'll forget everything. It will be jumbled up. Rather, you put them under the heading of metabolic liver disease. So if I say this baby is having metabolic liver disease, so what are the points going against? Is there anything to suggest metabolic? We agree this is probably biliary atresia. You miss the point of the stool color. Probably there is some confusion in the stool color. So it may be biliary. We agree. We are giving a grace mark to you in that respect. Nirmala,
Yes, sir.
you agree?
Otherwise, what are the features in metabolic? What will you find? If it's metabolic, what will be the features?
Lethargy, vomiting, seizure, dullness.
Lethargy, vomiting, seizures are very, very vague. Can occur in a number of patients.
For galactosemia, E. coli cysts will be there.
Yes.
And sudden deterioration after introducing hereditary factors intolerance, there will be sudden deterioration.
Prunta, you are not audible.
Not able to hear. Not able to hear.
You go close to the mic. Or turn your laptop towards you and be louder.
In hereditary factors intolerance, after introduction of any highly something, there will be sudden deterioration for the child. In galactosemia, there can be E. coli sepsis history. So after breastfeeding, the galactosemia, the symptoms are.
There will be vomiting, lethargy, failure to thrive. It will not be a well child.
Galactosemia was only cause for
Tyrosinemia,
hereditary fructose intolerance.
neonatal hemochromatosis.
In general, the babies with metabolic liver disease, they are sick. So firstly, you decide, is this baby healthy or sick? Otherwise, well baby growing well, then metabolic liver disease is less common. Most of the metabolic liver disease, babies are sick either at birth or subsequently they have septicemia-like illness. What you said that in isolation, vomiting, failure to thrive, they will have vomiting, failure to thrive, then hypoglycemic seizure, they will not grow well, they will be in and out of the hospital. So this kind of the sick babies. So there you consider metabolic liver disease historically. But if the baby is otherwise growing well, it can happen. If the tyrosinemia baby initially may be healthy, subsequently various presentation can happen with tyrosinemia. We are just concentrating on the neonatal cholestasis as a presentation, galactosemia, sick babies, your neonatal hemochromatosis, very sick baby. But if you see the HFI, their babies are not so sick, but they have the specific history of exposure to sugar, they will have vomiting, etc. So in general, they are sick baby. So this baby is not fitting into that category. Now, why, if we ask you that why not this is a case of progressive familial intrahepatic cholestasis, PFIC? Historically, what are the data you got to say this is PFIC or not?
In antenatal history, there is no intrahepatic colitis of pregnancy. And
There is a comment from the participant that your voices are not clear. So what
I am Dr. Srinivasan.
Sir, Srinivasan sir, welcome.
Yeah. Welcome. Yeah, I joined late because I had problem in getting the link. Yeah, but your voices are all clear, but no, all the faculty, but their voices are little feeble. I have to strain my ears to hear, but your voices are clear. Questions are clear, but answers are tough because he's nearer, I can hear. Kindly
Questions are clear.
make sure, yeah.
So Dr. Srinivasan, you are correct. I also had the difficulty in getting their voice. So I was repeatedly telling them either come close to the your laptop. Are you using laptop?
Yes, sir.
Yeah. So you do one thing, whoever is answering, you turn the laptop towards him or her and try to be louder. See, this is another attribute of scoring high marks. Even if you are telling a wrong answer, but if you are bold and clear,
confident,
you get credit. But even if you are giving a right answer, but you are not sure, you are fumbling, you are murmuring.
Sir, you mean to say the examiners can be fooled so easily?
No, but they assess their confidence. If confidently you are giving an answer means that, okay.
A confident bluff will be accepted. Then, yeah.
But means other way around. If you are giving a right answer, but it is not audible, then obviously you will not score.
Agree with you, sir. Yeah.
Okay. So why not? This is a case of if we say that this now we started getting many cases of PFIC, progressive familial intrahepatic cholestasis. Probably 20 years back, this entity was not known, and we are not diagnosing. Now we are diagnosing more. But obviously, it was there then also we missed. But now, why not this PFIC? A substantial proportion we do see, and Nirmala will agree with me. It is common in Chennai as well, isn't it,
Yes.
Nirmala?
Yes, sir. Yes, very common.
So this is not an uncommon entity or not a rare diagnosis now. We talk about biliary atresia, we talk about idiopathic nephropathy, we talk about TORCH, but we should keep PFIC is also a possibility. It's not uncommon. Tell us the point in the history. We said antenatal history only. Anything else?
During antenatal period, there was no intrahepatic cholestasis of pregnancy.
Can you describe what is intrahepatic cholestasis of pregnancy? Because you have taken history. What will you ask? This is a leading question you need to ask to the mother. Then only mother will be able to tell you. She will not come out with history that I was having pruritus during pregnancy.
Jaundice and pruritus.
No jaundice, only pruritus. Which phase of pregnancy? First trimester, second trimester, third trimester?
Third trimester.
Towards the late, third trimester. Okay. Anything else, any other history you get which will substantiate this baby might be having PFIC? This is only intrahepatic cholestasis or anything else?
Acute fatty
To the mother only? Any of you, three of you are sitting there. Tell us.
acute fatty liver of pregnancy.
No. Acute fatty liver is a rare diagnosis.
Different.
History of help.
No. What will happen? See that this what talking about the inherited condition, na? And it comes from the mother side. Similar history in the grandmother or maternal aunt, whether they had the ICP during their pregnancies, or very importantly, why do they have pruritus? Because of the hormonal changes. They will have pruritus with OCP, oral contraceptive pills. You need to go into the detail of that history, whether there is a history of cholestasis of pregnancy in the mother, maternal aunt or grandmother. See, mother may not have, because this is an autosomal recessive. It is not that everybody will have the same symptom. If you get fine, if not, then you go into the detail. Or the history suggestive of OCP-induced pruritus. That is also equivalent to your intrahepatic cholestasis of pregnancy. Did you take that history? No. So you should take so you should seriously take this kind of history. And then what happened to the baby? When the baby is born with a PFIC, historically what data you will get? Do they start itching or do they have pruritus at 6 weeks of age? This baby is 6 weeks of age.
Yes, sir.
They have usually incessant cry.
They have pruritus.
But,
When do they have pruritus? Manifest.
The pruritus manifests as incessant cry or irritability, sir.
Can a baby eat a 6 weeks of old baby?
No.
You can't. So you need
No, sir.
No, sir, no.
Because
you can't. So you'll not get history. Usually by the age of 4 months or 5 months, when they have a maturity of brain, they have a motor coordination. So then only see the baby cannot put their finger to a particular point and to start itching. Earliest features will be they will rub their head against the mother's shoulder, etc. But they don't have history of pruritus in the first month, second month, or third month, right? So you should say the age is not right to say that this baby is in pruritus or not. But I have taken the history that the mother, grandmother, or maternal aunt didn't have intrahepatic cholestasis of pregnancy or OCP-induced cholestasis. And this is the second baby, remember.
Yes, sir.
So what was the history in the first pregnancy? Usually the subsequent pregnancy, the mother will have the similar history.
Yes, sir.
Did this mother had pruritus in the first pregnancy?
No, sir.
No. Okay. So you didn't get anything to suggest PFIC. You didn't get any history to suggest it is a metabolic liver disease. And biliary atresia, we agree with a grace mark that intermittent pale stool. What about the torch infection? Can it be torch group of infection? It is commonly discussed that in everywhere that first you get the torch panel. Why not torch?
Baby is
Term
good
baby
term baby with
and
good
age.
birth weight of gestational age weight. It was not SGA.
So it rules out
Comes
intrauterine
against intrauterine infection, sir.
No, just not one point. You take the multiple points. First point is that is there any history to suggest torch infection in the mother?
No
When do the mother develop, if at all, in which trimester of pregnancy, if the mother develops, suppose CMV or rubella or herpes, and that manifests to the baby?
First trimester, there is no history. First trimester history, they had to take whether there is history of fever with rash or lymph node enlargement. There was no history of any infection at first trimester. And post-auricular swelling, no history of post-auricular swelling.
Very good. So you have to tell that in the first trimester of pregnancy, mother did not have history to suggest torch infection such as fever with lymphadenopathy, rash, vesicle, genital vesicle, this kind of, or jaundice, didn't have. So there is no historical data to suggest mother had. And this baby is born term with good weight. Usually, torch infection babies will be IUGR, isn't it?
Yes,
This baby was not IUGR. And if the baby had congenital any of this infection, it will not grow well. There will be the baby will be IUGR and there will be significant failure to thrive. In addition, they will have multi-system involvement. Besides jaundice, this baby will have micro or macrocephaly, rash, heart disease. You didn't get any history to suggest that this baby have multi-system problem, isn't it?
Yes, sir.
Okay. So any other possibility? Can it be some chromosomal anomaly, some kind of syndrome? Like if I say this baby Down syndrome or that kind of many chromosomal anomalies can give rise to neonatal cholestasis. Any historical data to support that? Mother's age?
Mother's age is 28 years.
So she is not elderly.
Yes, sir.
She is not elderly.
Okay. And again, the baby is thriving well. A Down's baby will not grow well, and there is no apparent dysmorphism as per the mother. Okay. So if you now analyze this, Dr. Ramchandran has raised the issue. I think that is, I wanted to brought this point that in context of intermittent yellow color stool. So did you read that question, Altaf? He said a baby can have intermittent yellow stool because of coating.
Yes, sir.
Outer surface of the stool may be coated with the secretion or exfoliation of the enterocyte which got bilirubin pigment. So what is your comment about that?
Sir, when in deep jaundice can happen due to the secretion from the intestines. Sir. It can get coat the stools and make it appear yellow colored. Sir.
Okay, so but this kind of description is just seen when the stool is form stool, means there is a formation. So outer coating is yellow, inside core is pale. But if this baby is passing semi-solid or liquid stool, then it is difficult to give this explanation.
Yes, sir.
Dr. Ramchandran, you want to make any comment?
No, sir, you have already explained. Oh, that's it. Thank you, sir.
Okay.
So I think the student will have to keep it in mind whether the stools have become firm, only then it is seen. I mean, just to, I'm just giving him a chance to have an escape clause, that's all. So we'll have to think of that possibility if
Yes,
everything is
definitely.
typical of biliary attrition.
This is a valid point, and the student should remember the explanation. See, we're trying to dig out that how do you explain that intermittently pale stool and sometimes yellow in a patient of biliary atresia, right? So, Altaf,
Yes, sir.
now summarize. Now, what are the points? Don't go your list of explanation. Whatever we have discussed so far, this is a 6 weeks old baby who is having jaundice from day 9. Initially received phototherapy without any getting bilirubin testing done. So
Yes.
we ignored that story. He is passing intermittently pale stool, and now you give the reason. What are the differential diagnoses you want to keep and points in favor and against?
Sir, since it's
Differential diagnosis. Number 1, you thought
biliary atresia, sir.
biliary atresia. Number 2,
Choledochal cyst.
choledochal cyst. Number 3,
Insipid bile duct syndrome.
They're giving a differentials for surgical causes.
So Nirmala, so they made up their mind that this
Yes.
is a biliary obstruction. So the differential diagnosis of biliary obstruction. So all 3 they have enumerated. Okay.
Other than
Okay.
that, can you give differentials? Other than that,
The metabolic disorder is ruled out from the history.
okay.
And the sepsis is also ruled out from history. And hypothyroidism is also ruled out. There is no delayed passage of meconium.
Intentionally, we didn't discuss hypothyroidism. This is actually a misconception. Hypothyroidism causes jaundice, but unconjugated hyperbilirubinemia. Hypothyroidism is not a differential diagnosis of conjugated hyperbilirubinemia. Having said that, I know it is given in the list of causes in the Nielsen textbook. So, but take it from me. Hypothyroidism by mechanism, it causes problem in conjugation. So there will be an unconjugated hyperbilirubinemia. And in a differential diagnosis of unconjugated, persistent unconjugated hyperbilirubinemia, you should rule out hypothyroidism, but this is not a cause of conjugated. Nirmala, your comment.
Yes, sir. It's mostly only unconjugated. It's not conjugated. But generally, because it's given in books where people they keep on.
This is the confusion. It is given in
Yes.
the list in the Nielsen.
Yes.
Now, the pan-hypopituitarism is a cause of conjugated hyperbilirubinemia, and in pan-hypopituitarism, you can get hypothyroidism. But isolated congenital hypothyroidism is not a cause of conjugated hyperbilirubinemia, right? So, don't go that this child doesn't have features of hypothyroidism, so we don't discuss hypothyroidism as a cause of conjugated hyperbilirubinemia. So there is nothing to suggest metabolic. You should talk about this PFIC. We discussed so much about PFIC.
What about PFIC?
PFIC can also be a possible term. We'll have to.
It can also present in neonatal period, but there's no history of irritability.
We discussed that see the pruritus doesn't come so early. You cannot say this is not PFIC. Only you can say PFIC is also a possibility. However, you did not get the history of ICP in the mother or OCP induced cholestasis in the mother or maternal side. That is a relative point. But it is not that all babies of PFIC will have history of pregnancy-induced cholestasis, right? But it cannot rule it out. Good weight baby, healthy baby, growing well at 6 weeks, you cannot say this is not PFIC. You can keep, right? So after biliary atresia, you can keep PFIC group, but metabolic liver disease less likely. Torch infection.
Hereditary fructose intolerance because baby is still on breastfeeds and not been started on any fructose. We can have.
Okay, we have ruled out. We have not thought of metabolic already.
If you say this baby is not exposed to fructose, then why the baby will develop jaundice? If it is due to HFI, see the symptom, you cannot be in isolation. You were talking about hereditary fructose intolerance, you are talking about the history of vomiting, diarrhea, hypoglycemia after exposure to fructose, and the same mechanism is responsible for causing jaundice and cholestasis. If the baby is having cholestasis due to HFI, then why he will manifest without exposure? You should not bring that, isn't it? Right. Now, I think there is a question raised by one of the judges that in which setting you express
Suspect
inspissated
bile syndrome.
bile duct syndrome.
The RH
In which
negative,
context?
Dr. Ramchandran, yes.
RH negative mother.
Look, you said na, that this one of the
What is
differential
it?
diagnosis is inspissated bile syndrome. So you should not have kept that possibility. Now we explain that once you utter a word, na, then examiner will ask to judge you that do you know this entity
Get
or
trapped.
not. So it is a trap. Now you tell us that when you suspect inspissated bile duct syndrome.
Mother is RH negative mother. And baby is RH positive. There can be hemolytic jaundice.
So background has to be a hemolytic.
Right.
So if you have a baby who is having hemolytic, mainly RH or ABO incompatibility, huge amount of bilirubin is produced, and that will get inspissated in the bile duct. So unconjugated hyperbilirubinemia with history of blood transfusion or excess transfusion, then the later part this baby become conjugated. You have started getting features like biliary atresia, but in the first part, like this baby has received phototherapy, but there is no history of blood transfusion or exchange transfusion. If you get, that is the setting, then only you will bring inspissated bile syndrome, but not otherwise. Right? So now, so what are the possibilities enumerated? One is the biliary atresia. Number two, don't talk about inspissated bile syndrome or choledochal cyst also. I am not very comfortable. Choledochal cyst can manifest like biliary atresia, but you don't have anything specific for choledochal cyst. Like choledochal cyst, baby have cholangitis, intermittently acyclic stool, though you said that, but no cholangitis, though it is one of the cause, but less common. Other than that, biliary atresia, choledochal cyst, PFIC cannot be ruled out. Fair enough. Nirmala, should we go for examination now?
Yes, sir. Yes, sir.
Okay. So historically, we have reached up to this point. Now let's go to the examination.
What is the importance of development in this baby?
Very good, Dr. Umar. Tell us the importance of development in the differential diagnosis of neonatal cholestasis. Baby is growing well versus not growing well. Uma, you wanted to mention that?
Yeah.
For any,
Yeah.
for any
Very good.
syndromic babies, chromosomal abnormalities, genetic causes, we have to ask the developmental history.
Did you
So
take that history?
Developmental is appropriate for age in this case, at 1.5 months of age.
So what are the development you have asked this baby?
It
1.5 months old.
yes, it recognizes the mother, makes cooing sounds. Social
contact.
So in the all the fields, how's the opening the hands and the responding to
Mother's words.
sounds?
yes, ma'am.
It rules out what?
Chromosomal and genetic.
So metabolic causes.
Metabolic causes.
So you told it is a consanguinate parents. Sir.
Yes, ma'am.
So 3rd degree consanguinity is there. So then which are the favorable diagnosis based on this?
Autosomal recessive conditions like galactosemia, hereditary fructose intolerance, tyrosinemia.
So any other There are so many metabolic causes are there. You told no recurrent respiratory tract infection.
Cystic fibrosis.
Any GI disturbance is there? GI disturbance.
Alpha-1 deficiency.
Citrate deficiency.
PFIC, if it is a PFIC, we have kept in the differential diagnosis of PFIC, isn't it? So if it is so many types are there. If it is any other associated problems that will occur in the PFIC also, the history you will get.
In PFIC type 1, there is associated anomalies like a failure to thrive, vomiting, growth retardation.
Why failure to thrive?
Because multi-organ involvement is present in PFIC type 1.
What are the organs?
Liver, spleen, pancreas.
The multi-system with the diarrhea and pancreatic involvement is also with there. So they will have a failure to thrive also. So it will occur in PFIC 1 and 2 also, which are more common in the neonatal period. Right, sir? So immunization, you asked immunization, isn't it? After immunization, what history you will get in this case?
Any bleeding man, the injection site.
Any hematoma formation.
So which will give what information you will get by this?
Liver.
Synthetic. Liver function. Coagulopathy.
Due to vitamin K deficiency. Caused by liver.
Dr. Uma, you are muted. Unmute yourself.
You're muted, madam.
Then we can go, sir. Next, sir. Shall we go, sir?
Oh, no. Yeah, you are doing very well. Uma, if you have anything else to add, because we, as a pediatric gastroenterologist, we look at the liver only. But you have rightly brought out the development part
Yes,
and that consanguinity. So
yes,
it's very important to take in account that what are the inherited condition giving rise to neonatal cholestasis.
yes.
Other than metabolic condition, PFIC, and some syndrome like Zellweger syndrome, Alagille syndrome, all these are all inherited. So, though theoretical, but you should remember if the examiner asks, since you said this is a third degree consanguinity, so obviously biliary atresia is not inherited. PFIC, yes. Metabolic liver disease, yes. But other syndrome, which are autosomal recessive inherited, Zellweger syndrome, etc., you should remember, right? And the development part is very important. If the child is not growing well, means having neurodevelopmental disorder problem. So maybe other than metabolic, your chromosomal anomalies are also important, various syndrome. Okay. Truma, should we go for examination
Yes,
now?
sir. Definitely, sir. Yes, sir. Yes, sir.
Let's give us the examination finding.
So on general examination, the child is alert and active. There is pallor and icterus. There is no cyanosis or edema, no dysmorphic phases. The head is normal. The anterior frontal is 2 into 2 centimeters. There's no cataract, no umbilical hernia, no limb anomalies, and external genitalia appears normal.
No, you cannot say no cataract. You should say no apparent cataract on torchlight examination. Isn't it? So unless and until you do fundal examination, you cannot rule out there is no cataract. So you should qualify your statement.
Vitals, temperature is normal, pulse is 140 per minute, regular in rhythm, normal volume. All peripheral pulses are felt. Respiratory is 46 per minute. BP is 84 and 66 in the upper limb. Saturation 99% in the room air, and blood glucose is 103 milligram per liter. Anthropometry, head circumference is 38 centimeters, measures at 50th centile according to WHIAP combined chart. Length is 55 centimeters between 3rd and 50th centile. Weight is 4.7 kg between 3rd and 5th centile. There is an average weight gain of 40 grams per day. Inspection. Child is examined in the lying position. Upper abdomen seems distended. All quadrants move equally with respiration. Skin of the abdomen is normal. No scars, sinus, or dilated veins. No visible pulsations. Umbilicus is midline. Flanks and hernial orifices of Pfizer. Palpation. Abdominal girth measures 50 centimeters. It is soft, not warm, not tender. The liver is palpable 5 centimeters below the right costal margin. It's a smooth surface. Spleen is palpable 1.5 centimeters along the axis. Percussion auscultation. Liver span is 8 centimeters along the midclavicular line. There's no free fluid. Bowel sounds are heard. To other system examination, CV is normal.
Can you go back to the liver slide, Altaf?
Yes, sir.
Yes.
Liver is palpable 5 centimeters. Then what are the other attributes of the liver? How do
You describe the liver.
It's a smooth surface, rounded borders.
Consistency.
Soft consistency.
Soft.
5 centimeters soft
possible?
liver.
Biliary attrition, soft liver. Huh?
Gayatri and Bruntha, did you examine this patient?
Yes, yes.
You agree with Altaf that this child is having 5 centimeter soft liver? Okay, tell me, how do you differentiate between soft and firm liver?
Firm will feel like the
Tip of the nose often.
And soft, like your
Yellow.
lobule, and
Yellow.
hard like your forehead. See, these are all traditional teaching, but when you examine a baby, you don't put your other hand on the forehead or to your lobule. See, there should be a semi-quantitative, some kind of objectivity in defining what is soft and what is firm liver. So in general, when the liver is firm, your margin becomes sharp, right? When the liver is soft, then margin is rounded. So you cannot say this is a firm liver with rounded margin. The rounded means if you imagine the liver has got a very thin slice of the margin. When you try to palpate, it rolls over your finger. So when the liver is normal liver, it's a soft liver, so it gives a rounded feeling because it is rolling over your finger. But when the liver has got fibrosis, inflammation, is a firm liver, then clearly you can delineate the margin. When you palpate the liver and you can clearly say that this is the margin, you can mark it. That is a firm. That is a sharp margin and firm. And see that you need to knit up a story. Like in the history, you said this baby is passing intermittently pale stool and biliary atresia. On examination, it is a 5 centimeter big liver with splenomegaly, and you say soft liver. Again, you said biliary atresia. It is not going hand in hand. You have to give right kind of information, isn't it? So, if I say this child is a firm liver, will you agree, or you want to go back and start exam? What was your feeling? Could you appreciate the liver margin clearly?
Yes, sir, it was
So that tells you, when
easy on
you
purpose.
can appreciate the margin, it is a 5 centimeter below right costal margin, that is a sharp margin and firm liver. But my point, you should not palpate your ear lobule or forehead or your nose to say it is a firm or soft. Nirmala,
Sir?
your opinion or your comment about firm liver, soft liver? Agree?
This definitely, once you are able to, as you said, if you're able to make out the edges clearly, then definitely it's a firm liver. As it rolls, then it cannot be a firm liver. This definitely could not have been a soft liver.
Dr. Ramchandran has raised an issue about this third centile weight. Can you comment on that? That the weight is a third centile is a wide range, third to 50th centile.
Sir, I raised it because between third and 50th centile, there are 3 panels. 3rd to 10th, 10th to 25th, 25th to 50th. Because if you are plotting in a growth chart, you should tell exactly because you are going to monitor the growth.
Altaf, your comment.
But,
You did a mistake.
Can't I
You
use
cannot
chart?
write 3rd to 50th.
Yes, sir.
So what Dr. Ramchandran said is right. So what will be the correct information? It is 4.7 kilo at 6 weeks of age.
The weight gain is good, sir.
No, weight gain is good. No, what he is raising the issue is a wide range, between 3rd and 50th centile.
The chart,
Is it usual to mention between 3rd and 50th centile, or there is another centile? That's what he wants to know. Out
The
that's what he wants to
which
know.
IAP chart we mark?
What have you used? What
Which IAP combined chart?
IAP?
Most likely, this child would have been between 25th to 50th centile,
Yes, sir.
isn't it?
Yes, sir.
You put it like that because you are putting in the growth chart. You are going to longitudinally assess this child.
Yes, sir.
The child comes later, sometime between 3rd and 10th centile. That means the child is going in a downward curve. Okay, so you should tell the centiles exactly.
This is a very good point, Altaf. You cannot fiddle with the anthropometry. You are going to become a pediatrician, and this growth chart, anthropometry, these are all our bread and butter. Right? This is the basics of pediatrics. This is the difference between pediatrics and any other branches of medicine. We deal with this growth. So you should be very careful in interpreting the growth parameters. Dr. Ramchandran, you are right. Okay, let's go ahead.
Sir,
We
thank you, sir.
interrupted you at the abdominal examination, and we want you guys to reconfirm the consistency of the liver. And then there is some issue about the interpretation of anthropometric data. Now, next, you are at the other system when I interrupted you.
Respiratory system, bilateral clarity is equal, no added sounds. Sentinel system,
Cardiovascular system, what have you looked for?
Any
those-
murmur
Mama, why?
for associated cardiac anomalies in Alagli syndrome.
Why do you get murmur in Alagille syndrome?
Where do you get?
peripheral, it's a pulmonary stenosis.
No. Peripheral pulmonary stenosis. Where will you auscultate? It is not in the precordium. Where will you auscultate murmur for peripheral pulmonary artery stenosis, which is a features of Alagille syndrome, though we are not considering, but as a part of the discussion, when you say the cardiovascular system, examiner will ask, what have you looked for in the cardiovascular system in a baby with neonatal cholestasis? So then you say the murmur, sir. Where have you looked for murmur? Nirmala, you are asking the same thing?
Yes.
Sir, cardiac defects can be associated with percentage of biliary atresia.
No, he's asking where will you auscultate in case of peripheral pulmonary stenosis?
Peripheral
Am
pulmonary.
I right, sir?
Yes. We're in the same boat. We ask the same question everywhere. Back. Yeah, this is not on the valve. It is a peripheral. Beyond your pulmonary your valve, you get the stenosis. So you are supposed to auscultate on the back for the murmur. Peripheral pulmonary artery stenosis, you don't get the murmur in the precordium, not in the second space or fifth space, right? So obviously you will auscultate precordium to look for murmur. There may be malformation in other, even what Altaf said in biliary atresia also, fair enough. Even other malformation is common in Alagille also. But prototype of cardiac malformation in Alagille is peripheral pulmonary stenosis, where you may not get any murmur anteriorly, but you will get murmur in the back, posteriorly, right?
Yes, sir.
Nirmala, correct?
Okay, sir.
Respiratory system normal. So neurological examination, Dr. Uma will now catch you. Give the detail of neurological examination. Dr. Uma, you please chip in.
What is the importance? of the central nervous system here. Is the normal means it rules out
Hepatic encephalopathy.
encephalopathy.
Why encephalopathy?
Bone will be decreased in hypothyroidism. AF will be wide open, and for that hypotonia child.
For Down syndrome babies, the limb will be hypotonia. Metabolic conditions may affect CNS also.
So in the general examination itself, we will see hepatic encephalopathy means what is the sensorium? You told the baby is alert and
Alert.
active and looking at the face of the mother, recognizing the mother, isn't it?
Okay, what are the positive findings in examination?
So there was only pallor, icterus, and hepatomegaly.
No, you should have enlisted. This the anthropometry is this baby doesn't have any wasting or stunting.
Yes, sir.
Dysmorphism very important when you are discussing a baby which is otherwise well thriving, intermittent fails too. So if there is a dysmorphism, that will suggest allergy. So you kind of should mention the important finding instead of enlisting everything. So this baby having good weight, good height, no microcephaly, no dysmorphism, is having jaundice with mild pallor. I guess mild pallor or significant pallor. Now
Mild
I'll catch you in pallor. So what is the significance of pallor in a patient of neonatal cholestasis? See, this is the problem with our pediatric practice or pediatrics training. I have also gone through this system of doing MD pediatrics. So that I tell my resident that in pediatrics you will get away with the two wrong information. One is mild pallor and another is just tip of the spleen. If you say there's a tip of the spleen palpable, sir, now the examiner will cannot deny the tip is palpable or not palpable. And the mild pallor. In India, probably all babies are having mild pallor. So now coming to the pallor, if you say this baby is having significant pallor, what is the significance?
Mild pallor, sir.
No, if I say that there is a significant pallor.
So take it that it's significant, the pallor is significant.
If there is a significant pallor, then how will you correlate? What are the conditions, Dr. Uma, you can chip in. What are the conditions where pallor will be a significant finding in a baby of neonatal cholestasis?
Cholestasis.
Incipiental bile.
The
No, you're not
incipient
able to
bile
hear
we
you.
discussed that, forget about
Incipiental bile
that.
duct syndrome, there will be hemolysis, it will lead to pallor and it.
That is already we discussed. For,
No,
other
no.
than that,
Consider among the differentials.
what are the other conditions you will
It's
start
rare.
thinking when there is a significant pallor?
Inspissated is rare. Other conditions.
Once you write something or commit something, then you have to defend yourself. Why have you written pallor? 6 weeks old baby, there may be a mild pallor, which is a physiological probably deep at 6 weeks
Nutrition.
of age.
Nutrition anemia.
Good weight baby, but if you say the pallor, commit pallors are like any pediatrician, tip of the spleen and mild pallor, then the examiner like me will catch you.
What's the cause of pallor in biliary attrition?
First tell us that what are the entities you think which are predominantly have pallor in addition to neonatal cholestasis?
Mala.
We are not talking about inspissated bile, not conjugated hyperbilirubinemia, like what the baby we are discussing with. What are the conditions where pallor may be a dominant feature? In galactosemia, you can get hemolysis. Okay, they can have pallor. Then there is an entity called
Neonatal.
giant cell hepatitis with hemolytic anemia.
Yeah.
Yes.
That is a specific entity, giant cell hepatitis. They have neonatal cholestasis and they have autoimmune hemolytic anemia.
Yes, sir.
So, theoretical discussion for this patient, but you should know when there is a pallor is a predominant of presentation and then baby is having neonatal cholestasis, giant cell hepatitis. So, it is basically autoimmune hemolytic anemia with giant cell hepatitis. That is the entity. if you have a metabolic liver disease, galactosemia, around 10 to 20% of galactosemia baby can have associated hemolysis, so they can have pallor. And what Nirmala was asking, that in biliary atresia also you can have pallor due to
All of them.
Nutrition.
nutrition will play in any condition other than nutrition. Nirmala, you just help them out.
What are the associated conditions? What is associated? What are the findings? What are the findings here? One can be due to malabsorption, as you said, or can be due to any bleeding.
Yes,
Conjugation.
because of
Portal hypertension, bleeding.
Portal hypertension, bleeding,
yeah.
or splenomegaly. Not that early. Hypersplenism is cannot occur this early. So
Right.
pallor generally is not very common in biliary atresia.
So if you get a significant pallor, so you have to remember that these are the conditions which can give rise to disproportionate anemia in a patient of neonatal cholestasis, right? So this baby doesn't have, I guess, the significant pallor. If at all, it is a marginal. And there is, why have you put
What about
it as
torch?
1+?
Torch, what about torch?
Yeah.
there is no microcephaly.
No, pallor. Anemia is common.
Anemia, yes. Torch, yes. Torch group of infection can also give rise to anemia, thrombocytopenia. So, in summary of examination, positive finding in examination, you should have, see that if you add plus, 1+ for pallor, 1+ for icterus, jaundice, it seems that this baby has equal amount of anemia and jaundice. It is not true. This baby is having more jaundice, isn't it? You should have added 1 or 2 more plus to the icterus. This is the problem of having this virtual meeting. We are not examining the baby. We are trusting you. And you are showing us you have not drawn a diagram. In this kind of presentation, you should have drawn the diagram of abdomen to show how big is the liver and spleen, etc. Instead of just writing the numbers.
If possible, even a picture of the child.
Yeah, or showing the picture with a showing how big is the liver. Now, after examination, where you are, how far we should go, Nirmala? Now, we'll sum up, or Nirmala?
We'll sum up.
Positive finding in examination is mainly you got a hepatomegaly, you said soft, but we are after you to say it is firm, and there is a spleen and jaundice, nothing else. Other systemic examination, you didn't get any murmur or a neurological abnormality, right?
Yes, sir.
Right. Now you add your examination finding to the history and tell us what are the differential diagnoses. Like we analyze the history and we come out with a 2 set of condition. One, you said the biliary attrition, and then said it could be, you cannot rule out PFIC. And others, you said that there is nothing to suggest. So metabolic liver disease or torch infection or chromosomal anomaly. Now, after examination, would you like to keep the same set of possibilities, or you want to add or delete? This examination finding is going well with your first possibility, biliary atresia. Sorry, I forgot to ask you. You already said that stool color, but in the examination, or abdominal examination,
It's mentioned. The next slide maybe it's there.
he said stool color in the history. He was the stool. Did you mention that in the abdominal?
Yes, sir. In examination also is brought, I think. Where is
Okay.
it? Here. Oh.
Okay. Macroscopic stool in the world every day. Pale stool. Right. Okay. Good. He could have kept a
photograph of the stool also.
Photograph of the stool would have been more objective way of showing. Right. So after examination, possibilities.
Well, still thinking of my first diagnosis, differential will be biliary atresia, sir.
No, not like this. If you say biliary atresia and put your point. Historically, this baby had blah 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 symptom, and on examination we got this point. So this is suggesting supporting the diagnosis of biliary atresia.
Yes, sir.
See, the clinical discussion is nothing but it is a giving positive point and point in favor, point in against. Then only, if you don't have any point against, then you will go for there is no differential diagnosis.
Yes, sir. Sir, so I'll summarize, sir.
If somebody go ahead.
You summarize your history and findings and give a diagnosis.
So 1.5-month-old,
Positive findings and give a diagnosis.
1.5-month-old boy baby, second born of third-degree consanguineous parents, present with jaundice since 9th day of life. Jaundice was progressive, with no history suggestive of any failure to thrive. Child was gaining weight, and associated with pale stools and high-colored urine. No significant antenatal history. With the
You are reading out.
anthropometry.
We cannot see your slide. No,
So
in the
he's
summary,
reading out from.
in the summary, you are reading out something or
Sir,
you
I was
just
telling-
verbally? Okay. Carry on, Uncle.
So, intermittent pale stools, just suggestive of obstructive jaundice. The examination revealing a well child with a reasonable gain in weight. The icterus was present and along with hepatomegaly. I'll go
You have
with
to change the consistency of your liver. You better make it firm. Okay. This in your examination. Yeah? Okay. Okay. What about the spleen? You didn't mention. You said there is a splenomegaly.
yes, ma'am, but it can be present in normally in the newborn.
So you think that is normal?
No, in this context, why you are not taking it in account? This baby is having 5 centimeter palm liver and 1.5 centimeter spleen. So, see, normal 1 to 2 centimeter spleen can be there, but this baby is having a underlying disease, which can also give rise to splenomegaly. So, take it as a positive point to
Positive
make a
finding.
diagnosis instead of telling that no, that is normal.
And if in case you have a splenomegaly in biliary atresia, what's the cause?
Any storage disorder and hemolytic disease.
No, it's a biliary atresia child as a spleen also. Then what is the cause of splenomegaly?
Total hypertension.
So that significant. No, then why you want to leave that out? Significant.
Okay.
Then
Can you get a baby of biliary atresia without spleen being palpable?
yes.
Yes, sir.
What is that condition?
Yes. Biliary atresia.
Splenic
Clinic
malformation.
malformation. Yes.
Yeah, that is asplenia
sir.
polysplenia syndrome. They don't have a single spleen, maybe having multiple spleen, and that's why you may not get a enlarged spleen. Okay, so you have to keep it in mind. Suppose you get a case like this where 5 centimeter big form liver, but you didn't get any spleen. Suppose the baby is slightly older, 8 weeks or 12 weeks. So then obviously examiner will ask you, at this age, after 4 weeks onwards, you will get the portal hypertension. But this child doesn't have big spleen. So how do you explain this with biliary atresia? Then we should come out with the possibility maybe associated polysplenia syndrome. See, the exam, when you have come prepared with a script, your script was intermittent pale stool. Your script was it was a soft liver. Your script was you didn't pay attention to the splenomegaly. But as an editor, as a examiner, we modified you. So in exam, you should be flexible. Don't stick to your gun. While giving the history, examiner interrupted you and said, no, it is difficult to believe that this is biliary atresia with intermittent pale stool. Probably there is a confusion of contamination, or like Dr. Ramchandran said, there is a outer coating. So then you should change your statement. That yes, though historically we got this history, but after analysis, probably this is the explanation of intermittent pale stool. I believe this child is having persistently pale stool, or maybe there may be occasional contamination. The same thing should be the liver. 5 centimeter soft liver in a neonatal cholestasis, then it doesn't go with a biliary atresia. So now go on with your summary and then differentials.
I'd like to investigate.
No, differential. Differential again after examination, you want to keep what are the possibilities you want to keep?
Any change?
No.
Investigation is basically related to your differential diagnosis. You should not start with investigating for allergic syndrome in this baby because there is nothing to suggest allergic syndrome. So your investigation primarily depend on what are the possibilities you are keeping, isn't it? So it is very important to analyze history properly and then examination and put 2, 3, 4, whatever the differential diagnosis, because in India it is not possible to investigate for each and every condition because we have the limited resources, we have limited facilities. So our purpose of clinical teaching will be to make a reasonably correct diagnosis and investigate them. If you draw a plan, then obviously you will expand your investigation. But you cannot start with a chromosomal a mutation analysis or MRI brain or doing something, some torch workup without thinking they are the cause. So give us the differential diagnosis and then we will go for investigation. Everything is already discussed. Now you just enumerate.
Neonatal
Your differential diagnosis. Number 1, 2, 3.
Number 1, biliary atresia.
Good.
Choledochal cyst.
Mm.
PFIC.
Okay. Anything else other than these 3?
No, sir.
Okay. Nirmala, you are happy?
Why choledochal cyst?
Is also one of the causes of obstructive jaundice can present in neonatal.
The examination?
How biased are you, Nirmala, about diagnosing choledochal cyst as a case of in neonatal cholestasis? I am against. In my
It is
experience,
not common, and no, with the 5 centimeters firm epitomegaly, I think after examination, I think you need not bring choledochal cyst or differential.
suppose there is a palpable lump and you have a history of cholangitis, intermittent pale stool, then choledochal cyst is definitely a possibility because the lump is more often palpable in infants than in older children because it's easy to palpate the abdomen and they have a big palpable lump. So you didn't get any lump palpable. If jaundice is persistently pale stool with a big liver, it's not suggesting, and there is nothing to suggest cholangitis. So I don't think choledochal cyst is will not be fitting in this differential diagnosis. I fully agree with biliary atresia, though with a caveat that intermittent pale stool is not going and your soft liver, but we qualified your statement, modified your statement to biliary atresia. Yes, PFIC is always a possibility.
We'll keep differential.
You cannot rule it out without investigation that this is not PFIC. Okay.
Yes, sir.
Now we'll start investigating. Now, will you show us investigation, Dr. Uma, or it is just a theoretical discussion on investigation?
Anyway, sir.
We have the investigation slide for this.
You have the reports, or you want to discuss the possible investigation?
Possible.
Okay.
You don't have the real-time investigation?
So we have ultrasound and the.
Okay, whatever I have, we will discuss later towards the end. Now you tell us, how do you investigate this baby? What will be your first? No, don't give everything in one slide. You go back. Previous slide. Okay, now you tell us what will be your first investigation. What do you want as the number 1 investigation in this child? You want to get this investigation first.
Bilirubin.
Want to do a
Only bilirubin?
Liver function test.
with total
No.
and fractionated bilirubin.
So that is part of neonatal jaundice. Now it has gone cross at that age. It is not 2 weeks old baby. This baby 6 weeks old has come to you with a big liver, spleen, jaundice. So you want a complete liver function test, isn't it?
Yes, sir.
Fractionated bilirubin is as a screening test. When there is a neonatal jaundice going beyond 2 weeks of age, like this baby went to a pediatrician who has given phototherapy without fractionated bilirubin. So that this should have been done that point of time. Fractionated bilirubin as a screening technique method. But when you are investigating as a cause of neonatal cholestasis, then fractionated bilirubin is not the only thing. You want liver function test.
Yes, sir.
You want that?
Completely.
Okay. What are the parameters you want in liver function test for this baby? One you answered that Gayatri said fractionated bilirubin. We agree. What else you want?
Want liver enzymes SGOT, PT,
SGOT, SGPT.
alkaline phosphatase, and GGT.
Out of these 4 enzymes, which one is the most important?
GGT.
GGT. What is the value of SGOT, SGPT to differentiate various causes of neonatal cholestasis? Does it help?
It is elevated more in hepatitis, sir.
Relative. There is a no significant difference of SGOTPT between biliary atresia or other causes of neonatal cholestasis. So we do it, but this discriminating value of SGOTPT is very limited. Except that if there is a associated hemolysis, you will get significantly high SGOT than SGPT. Other than that, OTPT doesn't help. But what is most important is alkaline phosphatase and gamma GT. So, what is the value of gamma GT in a baby with neonatal cholestasis? How does it help?
Normal or low in all normal or low, expect in PFIC3.
Only in PFIC? What are the conditions where you will get cholestasis with a normal gamma GT?
PFIC
There is
1
nothing called low, the gamma GT, there is no lower limit. What you expect high, it is not high, normal gamma GT. So what are the causes of normal gamma GT cholestasis? Your alpha is high, baby is having cholestatic jaundice, your conjugated fraction is high, but you are not getting elevated gamma GT. So what are the causes?
PFIC
One, we see the PFIC. PFIC, what type you will have normal gamma GT?
1 and 2.
Type 1 and 2.
Type 1, type 2. So at MD level, it is fine. We have type 5, type 6, so forget about those. Any other condition where you get low gamma GT cholestasis? Bolo?
Bile acid synthesis.
Bruntha, yes, very good. Bile acid synthetic defect. So we should keep that is also a possibility, right? Now tell me that you said you want fractionated bilirubin. What fraction is important? Value of total bilirubin conjugated when you pay attention to.
The direct one.
Total and
How much?
If
How
it's more
much
than
direct fraction
20%
is
of the-
qualified for to be labeled as conjugated hyperbilirubinemia?
If it's more than 5 milligrams, total is more than 5, and it is 20%.
5 milligram 5? No.
5 per deciliter.
Altaf, qualify your statement. If the total bilirubin is less than 5, then how much?
More
And
than
if the
1.
total bilirubin is more than 5, then how much?
If it is less than 5, it's more than 1, sir. If it is more than 5, it is 20%.
20%. Okay, that is a traditional teaching. You will not be deduced marks. You will get full marks. But in what is the recent development in neonatal cholestasis? At what level of bilirubin you should be careful,
15 to
irrespective of the total bilirubin? How much conjugated bilirubin is suggestive of neonatal cholestasis? Now, this is the relatively recent information, and it has already come into our guideline. Suppose this baby was at the day 9, was going to a pediatrician and he got a fractionated bilirubin. The total bilirubin was 15, but conjugated was just 1.5.
Yes, sir.
Would that be a significant conjugated bilirubin? Do you know how much is that conjugated bilirubin is now given importance? If you don't know, I'll give you the answer. Gayatri, Bruntha, no idea? This is 1. Irrespective of total bilirubin, especially after 48 hours of birth, if conjugated fraction is more than 1, then you need to keep an eye on this baby. This may indicate biliary atresia. There are recent studies to show that initially, because of this physiological jaundice, they have unconjugated fraction much more than what you expect, that 80%, 20%, 80%. But if the conjugated fraction, suppose this baby is having 1.5 at total bilirubin of 12 or 15, that is important. That indicates that this baby might be having biliary atresia, you have to keep an eye. So the definition now is changing. So any conjugated bilirubin more than 1 is significant. Right? That is significant. But your definition of what is the definition of conjugated hyperbilirubinemia, that's still valid. More than 20% or less than 1. But remember, in neonatal cholestasis, neonatal jaundice, not neonatal cholestasis, neonatal jaundice, any baby is having conjugated fraction more than 1, irrespective of the total value, is significant. Right. So in the liver function test, very important to know that it is a conjugated, unconjugated. So you are expecting conjugated hyperbilirubinemia. And second most important issue is gamma GT. Gamma GT will tell you is it normal gamma GT or elevated gamma GT. Now what you are expecting in this baby? Your patient, what you are expecting?
Raised.
Right, to be elevated, sir.
Gamma GT to be elevated. But you said that is the PFIC is a possibility. Why did you say gamma GT will be elevated? It may be normal. What you are expecting is total bilirubin and conjugated fraction will suggest conjugated hyperbilirubinemia. SGOTPT will be elevated anyway in any form of neonatal cholestasis. But very importantly, because you have kept two possibilities. One is biliary atresia, another is PFIC. And we are diagonally opposite diagnosis. And only one information you need is the gamma GT. So gamma GT will help you. So here comes the importance of gamma GT. And third subset of information is important, like synthetic function. So what are the synthetic function we have not discussed in the investigation?
Prothrombin
Albumin,
and prothrombin.
INR, prothrombin time or international normalization, INR and albumin both. Now what is the significance in a setting of neonatal cholestasis? INR and albumin, synthetic function of the liver.
later stages.
Suppose this baby is having, Dr. Uma also asked you this question during vaccination, bleeding, etc. Many a times we do get, suppose there is a prolonged INR, will that go for any particular diagnosis?
It is correctable by vitamin K.
Correctable and uncorrectable, very important.
If it is correctable, it is biliary atresia. If it is not correctable, it is a hepatocellular cause.
Very good. Then you have to think about metabolic liver disease. And if you get a low albumin, prolonged INR which is not corrected, that means baby is going towards decompensation early. So metabolic liver disease should keep as a possibility instead of biliary atresia. You don't expect biliary atresia baby to have hypoalbuminemia or uncorrectable coagulopathy, isn't it? Some of the PFIC can have coagulopathy early, like PFIC 2 can have more severe and progressive liver disease early on. So in liver function test, other than SGOTPT, rest are important. Fractionated bilirubin we discuss the value of gamma GT, we discuss the value of synthetic function. That includes not only INR, both albumin and remember, if your examiner asks, what about the synthetic function? You should come out, yes sir, I want to get total protein albumin and INR, right? Okay. Now there is a question. This is to Nirmala. Would you like to address this issue? After 14 days, conjugated bilirubin more than 2 milligram per dl, any setting, should we consider neonatal cholestasis?
Sir?
Benjamin, Dr. Benjamin has asked to all panelists. After 14 days, conjugated bilirubin more than 2. In any setting, should we consider neonatal cholestasis?
Yes, sir. Yes, sir.
My answer will be not 2, it is 1.
Yes.
It is 1. Any conjugated bilirubin more than 1 is significant. This is the latest guideline of our SPGAN, European Society of Pediatric Gastroenterology and Nutrition. Previously, it was 20% and less than 5, more than 1, and now it is 1. Okay. Next investigation, liver function test we discussed, and we are expecting this baby to have either high or low gamma GT, but we don't know. Do we have information? Do we have
Also,
the
they don't have the results. I think. They don't have the results. Altaf,
Um,
do you have the results?
slide la போடுங்க.
Reports. No, that.
Okay. Okay. Let's go with just a theoretical discussion. Next investigation. What do you want, Alta?
Sir, I want to do a complete blood count, sir.
You want CBC.
Yes, sir.
Why do you want complete blood count in this baby?
Sir, there was pallor, so I need to look if he's anemic. Second,
Suppose there is a pallor, then what will be the cause of pallor? You made diagnosis of biliary attrition.
yes, sir.
Rajendran, you have 20 minutes more. Okay. We have, it is a 2 hour session, so we almost finished.
Sir, and say if a biliary attrition, if you're planning for surgery, we need to know his baseline levels.
No, see, there are two ways to ask for investigation. The first is the investigation which is going to help you to make a diagnosis. See, this is not MBBS teaching. Now you are going to appear for the MD exam. You have to be more precise, isn't it? So you are going to become specialist. So the specialist will concentrate on diagnostic investigation. So you cannot tell like MBBS, I want hemogram, I want LFT, I want urine examination, I want renal function test, not like that. That's why we started with liver function test with an idea that this is conjugated or unconjugated. If it is a conjugated, whether it is a biliary atresia or something else, and how bad is the liver or how good by synthetic function. We analyze these three.
Yes,
Now next you said that I want complete blood count. Why do you want complete blood count? How it is going to help you to make a diagnosis in this baby? This is a routine
It's more
test.
important for diagnosis.
Now you have to come out the answer that these are the entities where hemogram is going to help, or complete hemogram is CBC will help.
To rule out sepsis, it's a base.
No, you have not thought of sepsis in this baby. We are not doing septicemic workup. Neonatal cholestasis, we discussed. See, you cannot forget the discussion part. In the discussion, well, while you showed the slide of pallor and we raised this issue, what are the conditions you get anemia? Now you bring that point and you tell me how CBC is going to help you. This is nothing to do with the biliary atresia. Biliary atresia, hemogram will be normal. We are not expecting anything. Even for PFIC also, your CBC is not going to help. Once you say committed, then you have to support. I said this entity, which entity presents with predominant anemia? Autoimmune hemolytic anemia with giant cell hepatitis.
It's a giant cell hepatitis.
Giant cell hepatitis, not giant cell hepatitis with autoimmune hemolytic anemia. Okay, so there your CBC might show anemia, high retic count, peripheral blood picture might show. But in a common garden variety of neonatal cholestasis where you are thinking it could be either biliary atresia or PFIC, there your hemogram is not going to help. Any other condition where your CBC will help? What you are looking for, basically. You don't say that I am looking for anemia. And if you are looking for anemia, why are you looking for anemia in this baby? Just 10 gram or 9 gram hemoglobin is not going to help you. What else you are looking for in a Complete blood count in a patient with neonatal cholestasis.
Thrombocytopenia.
Thrombocyte. In
Which condition will give rise to thrombocytopenia?
torch infection.
Very good. Torch will have thrombocytopenia, and Nirmala was telling about anemia in biliary atresia. Even in the biliary atresia, though it is early, suppose it is a 12 weeks old baby, then you could have got hypersplenism features. Yeah. Low platelet, low total leukocyte count anemia because of portal hypertension, hypersplenism. Low platelet is also an indicator of portal hypertension, right? But this baby is too early. So don't backtrack. Once you said I want CBC, hemogram, then you come out, why do you want CBC? To diagnose biliary atresia? No. But as a complication of biliary atresia, what Nirmala said, portal hypertension, you can get thrombocytopenia. Similarly, you can say neonatal cholestasis, maybe because of TORS infection, there I can get thrombocytopenia, anemia. Then you can say there are rare entity which give rise to neonatal cholestasis with hemolysis. There I get the picture like hemolysis, like galactosemia or autoimmune hemolytic anemia with giant cell hepatitis, right? Okay, next investigation. So when you present a case, you should focus on diagnostic investigation first and then general investigation. Don't go by this the dictum that you have to start with hemogram, then LFT, then urine examination, then chest X. Not like that. The investigation which is going to help you to make a diagnosis. LFT, yes, fast. Second investigation.
Out of ultrasound, sir.
You want ultrasound. Very good. What you are looking for? What do you want your sonologist to provide information to?
If there is a gallbladder present or not, sir. If it's visible or not. And
What is the
any
precondition of doing ultrasound in a baby with neonatal cholestasis?
4
When you will
hours.
send a baby for neonatal ultrasound, what precondition is to be
After
fulfilled?
4 hours fasting, we
4
have
hours fasting, sir.
Okay, fasting. Minimum 4 hours, ideally 6 hours, but 4 hours fasting. You ensure fasting. Why do you want this baby to fast for 4 hours to get an ultrasound?
So the gallbladder will be visualized. It will be full and it will be visualized.
What happened to the after feed to the gallbladder?
It will
contract.
Contract. So gallbladder contracts with a feed. So you want a nice distended gallbladder in a patient with cholestasis to develop. What are the findings you are looking for? See, you need to give the information to your sonologist that these are the finding entity I am considering. So we provide information related to that. So what are the information you are looking for in ultrasound in a baby with neonatal cholestasis?
In biliary
Like this
atresia,
baby.
the gallbladder will be smaller, non-visualized, and a triangular cord sign will be seen, and ghost triad will be
And
ghost gallbladder ghost triad.
ghost sign. Okay. You said gallbladder is either absent or contracted. Can you get a
Small.
visible gallbladder?
Yes, sir.
Yes.
In
And what happened to that gallbladder? Suppose gallbladder is not atretic. Sonologist said, I could see a gallbladder which is around 15 millimeter. Then what will be your next question to the sonologist?
is the
There are if you go to the anatomy of biliary atresia, there are type 1, type 2, type 3. On
Yes, sir.
fully atretic type 3 biliary atresia, gallbladder is also atretic.
Yes, sir.
But if you have type 1, type 2, where proximal part of the biliary system is atretic, distal is patent, and some of the cases can have well distended gallbladder.
Yes, sir.
Then what other information will help you to say this may be a variant of biliary atresia where gallbladder is visible but proximal bile duct are atretic. So what ultrasoundologist will tell you?
Is
Ultrasound finding.
bile flow, sir.
No. Post feed.
Post-feed contraction.
So when you are sending the baby fasting to look for distended gallbladder, so you want answer on two accounts. If the gallbladder is absent, then there is no question of giving a feed and looking at it again. But if gallbladder is distended present, not you need to see the contractility. After feed, again repeat the scan to see at least there is a good contractility, means at least 60% reduction in the volume of the gallbladder from fasting to postprandial. So that will rules out gallbladder. That means there is a patency, there is a communication between the intrahepatic bile duct to gallbladder and gallbladder to duodenum. So gallbladder is contracting. But if there is a gallbladder which is actually nothing but a mucocele, there is some secretion in the gallbladder but there is no bile, it looks distended by the sonologist, but it will not contract after feed, right? So what else other than gallbladder? What else you want? You say triangular cord sign, very good. What else you want to know from a sonologist in a patient of neonatal cholestasis?
The liver and the intrahepatic biliary.
Before liver, you already said one of the differential. Rajendran, how much time we have? 10 minutes more? Yes. So how do you diagnose cholestatic cyst? Ultrasonologist will give you the diagnosis. So when you say it is cholestatic cyst, you have any idea how much is the diameter of a CBD in a neonate? And when you say it is cholestatic cyst? 1.5, more than 1.5 millimeter. See, remember one thing. If the sonologist says that there is a small gallbladder, however, CBD is seen, then you start thinking this could be cholestatic cyst. Normally, it is very difficult to ascertain CBD in a neonate because the CBD diameter is less than 1.5 millimeter in a normal baby. More than 1.6 is dilated CBD cholestatic cyst. So if there is a nice distant, nice CBD seen, then start thinking it is a cholestatic cyst. Okay. So the cholestatic cyst is diagnosed sonologically. So beside gallbladder, you want to know whether there is a cholestatic cyst or not. Rest of the liver parenchyma etc. is non-specific. That is not going to give you a diagnosis. Suppose there is a irregular outline, alter ecotexture suggesting of chronic liver disease. But who is diagnosis? It could be metabolic liver disease, it could be late phase of biliary atresia, even type 2 PFIC can also. It is not going to give. You want information to make a diagnosis. So ultrasound is for gallbladder to look for cholestatic cyst. And now they said instead of triangular cord sign, the echogenicity anterior to the right portal vein. That is a more precise. If it is more than 4 millimeter, echogenicity anterior to the right portal vein. Previously, we used to talk about this triangular cord sign. Now that has been replaced by more specific. You focus only the echogenicity anterior to the right portal vein. It is easy to get that information, right? What next after LFT ultrasound or CBC? What next you want to do?
And do a HIDA scan.
You want to do HIDA scan. So let's discuss what is the role of HIDA scan in the diagnosis of neonatal cholestasis. What is the role? How does it help by doing HIDA scan? The information provided by HIDA scan will help you in making what diagnosis?
Hepatocellular causes from obstructive causes, essentially neonatal hepatitis and biliary attrition.
What will be the finding on HIDA in a patient of biliary atresia, and what will be the finding in a patient of neonatal cholestasis of other causes, suppose PFIC?
Biliary atresia, there will be uptake, but there will not be drainage of the thing into the intestine, sir. No excretion even.
In hepatocellular causes, the uptake is decreased, but the excretion is good.
Are you sure you will get excretion in all cases?
No,
when you
sir.
have a deep jaundice, significant cholestasis, see that you are discussing a baby who is having pale stool. What pale stool means? There is no bile. Bile is not coming to the duodenum. That's why the stool become pale. In such a baby, will the HIDA scan going to help? So what is the actual role of HIDA scan? HIDA scan is a good investigation, but it helps in
early stage.
In which way? You know, you do investigation for two purposes. One is the positive, another the negative. You want to make a diagnosis with some investigation, and you want to rule out with some investigation. So HIDA scan plays a role in ruling out biliary atresia. When you have a doubt that it could be, like if your history is correct, intermittent pale stool, then it is not biliary atresia. So you have a doubt. In that case, you do HIDA scan. HIDA scans show excretion of the radioactivity in the duodenum that rules out biliary atresia. but you don't ask hydroscan to prove a diagnosis of biliary. You cannot. In all form of cholestasis, there may be a poor uptake or good uptake, and there may not be excretion, but that will not prove this is biliary atresia. So hydroscan in specific cases where you have an ambiguous stool, you have a doubt about this ultrasound finding, you want to rule out. There is no excretion, so biliary atresia ruled out. You got my point?
Yes, sir.
Okay.
What next? You got LFT, you got ultrasound, you got CBC, you got hydroscan. What other investigation you want to do in neonatal cholestasis? Pardon?
Liver biopsy.
You want to do liver biopsy. Very good. So what will you look for in liver biopsy? What are the conditions you can make a diagnosis on liver biopsy and where you will not do liver biopsy at 6 weeks of age?
For
Suppose let's take this child, our patient, index case. Here you do liver biopsy at 6 weeks of age. So what diagnosis? You kept two possibilities. One is biliary atresia. Is it going to help liver biopsy? Answer is yes or no. Yes.
But
Yes, liver biopsy. Out of all investigation, liver biopsy is the most accurate to differentiate biliary atresia from other causes. Yes, it is going to help. Do you have any idea about what is the gross liver biopsy finding? It may be too much for you.
So there will be
bile duct proliferation and fibrosis, and
Very
that,
good.
presence of bile lakes, and there will be minimal giant cell formation, and the hepatic architecture is preserved.
Good, very good, Gayatri. It's basically you looking for the portal tract expansion with fibrosis, bile duct proliferation. Okay. Now question is the second possibilities. PFIC. Is by liver biopsy going to help to make a diagnosis? Can you get some information in which can help you diagnose PFIC?
Bile flux will be present.
Nothing. These are all non-specific. You can give a bland cholestasis. You can get the giant cell hepatitis, non-specific. But you can do something special. Nirmala is smiling.
Yes.
Type 2, in PFIC type 2, there will be giant cell formation.
No,
Pardon?
an extra.
Yes, positive staining.
Not routine hematoxylin stain. Can you do any special stain which will help you to diagnose PFIC? This is extra marks. You have already passed. You have scored 70%. Now I will give you 30% extra to make it 100%. If you can answer this question. Especially PFIC 2, PFIC 3, you can do some kind of staining. What is staining? What is the special staining? Not exactly staining, special technique.
Yes.
What do you do for leukemia?
They have some idea. You can say, yeah. In the bone marrow, you do something for leukemia.
To diagnose, to type leukemia, what do you do?
Yes.
Immuno?
Tell us, Gayatri. Immunohistochemistry. Yes, very good. You can use the antibody against the antigen. So in type 2 and type 3, there is an absence. So in the type 2, bile salt export pump is absent. So if you give this antibody, and you will not get any staining in type 2. The same thing in type 3, there is MDR3 is absent, and if it is you give the antibody, you will not get staining, that will suggest. So routine histopathology does not help, but immunohistochemistry helps in making a diagnosis, right? Yes. Right. Nirmala, how far to go now? We finished?
We have only 5 minutes left, I think.
Sir, 5 minutes only, but okay. Anything else you want to do other than liver biopsy? Suppose it is a biliary atresia, you are not getting clue on ultrasound and liver biopsy. What will you do?
Intraoperative cholangiogram.
Perioperative cholangiogram. So you will ask your pediatric surgeon to do either laparoscopic or open cholangiogram, and that is a gold standard. If it is a biliary atresia, what will you do? 6 weeks. Well,
you can do a
Kasai photo. Very good. Pardon? Yes, Gayatri?
Simultaneously, we can do the Kasai procedure.
Yeah. If it is a biliary atresia, I will go ahead do the Kasai photo interstomy. Very good. Excellent. Now, can we see those investigation slides? You're done. Your case is over.
Only ultrasound you have.
Rajendran, Dr. Rajendran, anything?
Sir, you can proceed, sir. No problem. You can take time, sir. No problem. Proceed.
Okay, okay. So ultrasound, can you?
The gallbladder was visible, sir, with normal wall thickness, and CBD was not dilated. And
See, this is the problem. We have the adult radiologist, so they will apply their common adult type of information. Gallbladder is visible. He has not given what is the gallbladder size. He has not given fasting volume and postprandial. So you discuss theoretically, you want to send this baby after 4 hours of fasting, but your sonologist is not written anything how much is the fasting and postprandial. You cannot say there is no biliary atresia looking at this ultrasound, right? So you need to have a collaboration with the sonologist. You should pass on the information. What is your question? Investigation is basically asking for question and getting the answer. So radiologist should be told, I am suspecting biliary atresia. Please look at the size of the gallbladder, pre-feed, post-feed, right? Then only he will be able to give you the information. Otherwise, he is doing ultrasound to a 70 years old lady to find CAGB or gallstone, and then a 6 weeks old baby. So he doesn't know what information he is supposed to provide. Okay, HIDA scan.
there is uptake, sir, but there is no excretion.
Okay, no excretion. Up to what time you will look for?
24 hours.
Approximately 24. No
24 hours.
delayed. Sometimes there may be delayed excretion. So usually you get excretion within 2 hours. But when there is a poor uptake, it may be delayed. So you have to take a delayed film up to 24 hours, no excretion. That suggests, but it is not diagnostic. Next, anything else we have? We have a LFT.
So LFT I did not put, sir.
See, this information, you cannot take it that nuclear medicine people say this is biliary atresia. We discussed this.
Yes, sir.
If there is a excretion, they should say no biliary atresia. That is diagnostic. But no excretion does not mean biliary atresia. We have any other information?
Sir, the interop findings were there, sir.
Oh, this is already POC done. We don't have LFT, gamma GT.
Sir, it is.
If you have, you can read it out. Altaf.
Yes, ma'am.
We will read, ma'am.
Yeah.
LFT total bilirubin was 8.4, direct of 4.7.
Not able to hear.
Louder. We cannot hear you. Loud.
Total bilirubin total was 8.4 with the direct 4.7. SGOT 125, SGPT 69, DGT was 987, and alkaline phosphatase was 658.
Altaf, we cannot hear you. Why?
His voice is not.
I think you're not closer to the.
Voice.
Ma'am, can you hear me, ma'am?
Now you're able.
No,
Please.
Bilirubin is 8.4, direct of 4.7, SGOT 125, SGPT 69, GGT was 997, alkaline phosphatase was 658.
So this LFT is suggesting not PFIC but biliary atresia, high gamma GT, na? You have a 997.
Yes.
Okay, very good. What is the perioperative cholangiogram finding you are showing?
It was atresia of entire extrahepatic biliary tree noted with no apparent lumen. Bile drainage is not appreciated.
So your sonologist is wrong. Your ultrasound say the normal gallbladder. So don't trust. Trust yourself.
ultrasound was
You
done
first ask
outside.
question. No. Outside is a radiologist, man. He is also qualified radiologist. So you cannot ignore him. But see, this is objective finding. This baby had type 3 biliary atresia, no gallbladder at all. Okay. So done. We finish what we suspected. So there are a lot of caveats. So what have you learned, Altaf? Learning point from today's discussion.
Sir,
Rajendran, we take a couple of minutes more.
Yes, sir. You can proceed, sir. No problem.
Okay. Learning point. 3 of you. Altaf, Gayatri, and Bruntha. What have you learned today? What
History,
you came
sir.
with prepare, and then something you destabilize you. And at the end of the day, I guess you have learned something. What have you learned?
To get a proper history of the pale colored stools, the persistent
History
pale
taking
stool.
is very important.
Yes, sir.
History taking, you faltered. See, writing no is not important. You prepare 5 slide, 4 slide is no. No is not important. What is yes is important. So you have to go with a positive frame of mind. If your baby is having neonatal cholestasis and these are the 4-5 group of disorder and you ask question related to that. If you say there is a pale stool and you are thinking biliary atresia, then you have to qualify if it is really persistent or intermittent. If it is intermittent, what is the reason for intermittent, right? So the history is very important. And then what have been the second point you learned?
Examination of liver.
Very good. Examination, you should not commit 5 centimeters soft liver, right? So not that palpation of your ear lobules or your nose or your forehead. You trust your finger, feeling on the finger. Can you appreciate the liver age or not, right? So that will help. And the third learning point is?
Conjugated bilirubin more than.
Yeah, very good.
Direct,
Excellent.
more than one.
One. And fourth point, investigation. Investigation approach. You should not be starting with hemogram. It should be investigation relevant to the diagnosis, which will help you to diagnose, right?
Yes.
Okay. Nirmala, would you like to add something? And then Dr. Uma, you are, sorry, I have not involved you actively.
No, sir.
Altaf,
Nirmala?
please stop slide sharing, please. Thank you. Yeah. Madam, Uma, madam, please. Yeah.
Yes, sir. No, sir. They have asked everything, sir.
Okay.
And I focused on that history-wise immunization and development other things. This perinatal, one thing I want to, Jal sir, if it is a perinatal onset of biliary atresia, will it be liver softness? Any difference will be there?
Ma'am, actually, these are all misconceptions. There is nothing called perinatal or embryonal variety. This used to be the belief. Now we have a strong evidence to say that biliary atresia is actually congenital. This happens during the organogenesis because biliary atresia is diagnosed in preterm babies. 32-weeker born with biliary atresia, you do Kasai, they do better than when babies operated at 40 weeks. So all these features suggest that concept of perinatal, that it can start at birth or after that, this is absolutely a wrong perception. So we should go away with this idea that a baby can born normal with bile duct and later on develop biliary atresia.
That yellow alertness. So in this case, doctors, we had given phototherapy for this child on day 9, but the patient came by themselves to the hospital because of increasing yellowish discoloration at 6 weeks of age. By themselves they came. So this gives the importance of our yellow alertness, isn't it, sir?
Excellent. I am very happy to see, even in my center, Dr. Yacha tried 20 years spreading this message of yellow alert, but we are not successful. In my state of Uttar Pradesh, Bihar, and North India, we get babies coming at 3 months, 4 months, 6 months of age with biliary atresia. But I'm happy to see that it is not the doctor, the mother herself has come to your center at 6 weeks and got the biliary atresia operated. Excellent. You should keep it up. You should expand this yellow alert to all district of your state of Tamil Nadu and adjacent states. Very good. I will suggest you should take the help of this tool card. Mother has just randomly has come. If you can distribute this tool color card to the peripheral doctor where delivery is taking place, that is going to change the whole scenario. We'll be able to pick up more biliary atresia earlier than 6 weeks also. Thank you, Dr. Uma. It is an excellent
Yeah, thank you, sir.
perception.
I request Dr. Srinivasan, sir, please comment, judges. Dr. Srinivasan, sir. Dr. Srinivasan, sir. Yeah. Okay. Dr. Srinivasan, sir.
Yeah, I came in a little bit late. So otherwise, of course, enjoyed the way, in a very humorous way, the case has been discussed without tension, and all the points were covered. And this is the second time we are listening to your excellent discussion, sir, Dr. Ujjwal. Thank you so much. And students, of course, they've done well. And they're smiling and tensionless. That was a very encouraging sign. Yeah. And excellent discussion. Thank you so much. Of course, I haven't given marks because I joined a bit late because I couldn't get in with the. Thank you
So
very much.
you should give marks listening to the last comment that what they have learned. This is the most important part, the self-appraisal.
Yes, sir. Yes, sir.
They declare themselves that they have faltered at history taking, examination, investigation. So they should get marks.
Yeah, this is available in IAP TNC YouTube, sir. You can see and give mark. And I request Dr. P. Ramachandran, sir, please comment, sir.
Thank you, sir. Good evening. Students did quite well, and they were very comfortable, and they were made to be quite comfortable with our excellent faculty also. And congratulate and appreciate Professor Nirmala's and Dr. Uma's comments and their inputs. And the learning point for me in this session is Professor Poda's way of not only keeping the students at ease and also the colleagues and all of us extremely at ease. And this is one of the best ways of bringing out what the student knows rather than what he doesn't know. So it's a very important learning point for us. Thank you, sir. Thank you so much.
Yeah. Now, Dr. Ramesh, sir. Dr. Ramesh.
Good evening, sir. This discussion was excellent because there was excellent coordination between the chairperson and as well as the moderators. They were complementing their knowledge and experience to each other. The students also did much better today because of their active participation. All the three participants are involved in the discussion, and especially the latter part of the discussion, they did extremely well, though they fumbled a little bit in the clinical examination and history taking. And Professor Pfizer was nicely telling them in a non-threatening way how to look into finer details. I think he stressed the importance of the finer details. As regards the clinical findings, I think three participants should have their own independent findings also. If there is a controversy among themselves, it should be brought out also. It is, after all, it's a discussion and a learning process. So even if you're wrong, you need not worry about it, because once one can say soft, the other person can say firm. And they let the the moderators will give the points how to differentiate between these two. This is a learning process. So anyway, there is a lot of improvement. I should congratulate Dr. Rajendran for arranging such excellent discussions for the benefit of the PGs. Thank you very much, sir.
Thank you, sir. Now I request Dr. Ramachandran. Yeah, please.
Good evening to all of you. As usual, I think we are the beneficiaries, although we call, at least I'm talking about myself, calling myself a judge, but I'm learning during every session. We had a similar session about a couple of weeks ago, and we realized that each faculty takes get to learn so much. We look at it, the perspective is different for each faculty, and today it was extra hepatic biliary atresia. I think last time it was cholestasis. Whatever it is, these three people, I think the credit goes to the faculty, Dr. Podar, who was able to involve all the three. Usually there's one person who's talking and the other looking out, but all of them seem to have adequately prepared for this session. And I was asking Nirmala whether it is necessary to mention the abdominal circumference, the girth. I don't know, it's given a lot of importance in most of the presentations, but I did not think it was necessary. So I was asking her about it, because I don't think there's any fixed or any